Yes.
For the next TAVR case, yes.
Yes.
So this is a 68-year-old female who had presented with shortness of breath on exertion. So history of Hodgkin's lymphoma and prior radiation chemotherapy, and has had several other comorbidities, already as a pacemaker. So was diagnosed to have severe AS, gradient you can see there, 52-29 with the moderate AR. And another confounding factor is that also has moderate mitral stenosis with a gradient between 6 to 8. So medication-wise, just on furosemide, as you see there, and Kath had shown that she had a non-obstructive coronary disease. So this is her transthoracic, previously recorded. So look at the valve, thickened, calcified. Could it be part of radiation also, right?
Yes.
Yes.
Yeah.
Oh, yeah, he's
Yeah.
coming here.
Yeah, absolutely.
He needs a
This looks
micro.
like radiation valve disease. There's also a MAC calcification, mild to moderate MS. There's leaflet thickening. So definitely part of it is radiation valve disease.
Going to take that away?
And also some LVOT calcium.
So you show.
Yeah.
Yeah, definite LVOT calcium.
So that we can discuss about, Tarun
Yeah, we'll see
presented.
you on the CT. The CT
Yeah,
really
Tarun presented a great talk on valve choices. So we can talk about valve choices here as well. This is a great case for that.
Life.
Yeah, let's look at the CT.
Always.
Okay, next.
Dr. Kinney, you want to show?
Yes, I'm showing the CT. 1 second, let's go back. Oh, did you want to see the,
yeah.
okay,
So
slides
this is,
for the?
yeah, so Stan, you want to show the echo first, or?
Yeah, I mean,
No, finish the CT.
you put it on, yeah.
Okay, let's finish the CT and then you can show live on echo, just in the interest of time. So you can see there's a small annulus, right? 350, 360, and then small LVT. But look at the calcium rim. This is extending down to the mitral, aortic mitral current, and mitral valve. Next slide. And you can see that the aortic root most is clean, low flow, low gradient, but also fibrotic radiation like heart disease. You don't see a lot of cavi calcium in it. That's a very classic what we've seen in this type of population, consistent with history. Next slide. So you can see, some ascending aortic calcification, but look at the MAC going down there. Look at the bottom right image, the coplanar view. That's not aortic valve. That's the mitral valve with the MAC. And you can see the unfluoral once Sahil showed you unfluoral. So certainly this is very consistent. Next slide. So access is pretty straightforward, young lady. So no surprise. Next slide. And arch anatomy is okay. So next slide.
We there was almost no radial pulse, so there's no sentinel here, but
Previous radial cap.
Maybe.
yeah, there was a radial.
Sam, you want to show some images, or you have any
if I can
images?
put it on the
Echo?
display, it would be great.
You want to show the echo. So essentially she's here for a TAVR. The question is same. I think the discussion should be the valve choice,
Okay.
right?
Yeah. So maybe the panel can answer how they treat these patients and what's their valve choice.
Tarun, what are you doing in LA with this patient?
I think NAVITOR is a very good option for this patient. Given the LVOT calcium, you'll get excellent hemodynamics, and it'll be a good landing zone for future TAVR. And clearly with radiation heart disease, surgery will probably be high risk now and in future. Yoshi?
Yes and no. I think this mitral valve will be a problem in the future. And then now you have a TAVR valve in, and you've got a mitral valve issue, which is going to make it even more complex. But if we were going to proceed with TAVR, I would probably pick a self-expanding valve. I think this is definitely a higher risk for paravalvular regurgitation.
Radial
Steve,
balloon.
Steve, what do you think in Texas? Self-expandable, LVOT calcium?
Probably go self-expanding, I think, on
Yeah.
this. Yep. Yep.
I can show you the echo. As you can see, normal LV function. Aortic valve is thick and calcified, doesn't move at all. The aortomatral cortin is calcified. Also, anteromatral leaflet doesn't move at all. No pericardial effusion.
So good. So you can see in the echo, right? Everyone in the panel, in the audience, you can see that despite not much leaf-like calcium on the CT scan, the calcium scores can be low on the CT scan. Look at how thickened and fibrotic and stenotic it is.
Yeah, mild AI.
So the question to the panel is that would you pre-dilate looking at the echo and the CT in the context of this particular platform that we're going to implant?
Who wants to pre-dilate with that valve and LVOT calcium?
think with Portico, you must pre-dilate. It's a, the valve frame is, because it's open cell, it's relatively weaker compared with Evolut or Sapien. So I think we learned that in the early part of the Portico trial. Pre-dil is very important for Portico especially. So I think you will need to pre-dilate this valve.
Yeah, so that's what we're waiting for. We want to pre-dilate, but also we were thinking about post-dilate, but as you know, with the calcium there, we're thinking about a semi-compliant balloon rather than a non-compliant balloon because of the risk of root injury.
So Gilbert, while you guys are just getting ready, can you just show us the mitral valve live here with your TE? Or you
Yes.
have a
Can
TE in?
you, it's a transthoracic. Oh,
Sure. We have,
Oh, you have transthoracic. Okay,
Dr.
that's even
Adams
better. So
missed
can you
you.
give us a
Yes.
gradient live?
Yes.
Turn the color on
you
so we
so
can
happy to
set
hear
the
you.
acceleration.
Yes.
You
Some TR here.
Keep going.
Short axis. Not the best imaging.
It's
Normal
150.
function.
Pull back.
8 millimeters gradient through the mitral valve. So we got Dr. Adams 3.6
Okay.
velocity here. On the echo that was done before he comes to the patient came here was about 4. The maximal velocity. Here the maximum gradient is 52. The mean gradient is 33.
Get me the valve.
And the aortic valve area comes down to 0.6 centimeters square.
I think you want to see the mitral valve,
The-
right?
Yeah, the mitral is what I was trying to get you to show us the real gradient of the mitral valve right now.
I think it's at 8 on that measurement.
The gradient is 8.
Yeah, because I mean, this is the question is
right.
if, just to echo what's already
20
been
divided
said,
by 0.9.
we'll let you guys focus and then we can talk about the case too.
By pressure half time, it's like moderate mitral stenosis.
Well, that's not moderate, is
You're
it?
good. You're good. That's Mac.
Yeah,
Be careful.
Yeah, we're not.
What's our review?
You can pull back, yeah.
Pressure half time of 73. So 220 divided by 73.
What's the gradient you're getting stamped?
8 millimeters. 8 millimeters mean
Bring the
gradient.
lights, please. Let's go to TAVR mode.
So what we did was that we actually, with this system, because it's very flexible, I need to see the pigtail, please. Sure. It's jammed up.
Right.
Is that it tracks along the curved aortic arch very nicely.
Good.
And then also we
Keep going.
intentionally go deeper and then pull back to center the catheter, because if you don't do that, you're going to end up missing the
20.
left
73.
cusp. So this is the vision marker. You can see we basically go inflow, inflow.
So we're releasing it. Looks pretty good so far. Pretty stable, centered.
No
No
pacing,
pacing
required.
here whatsoever. Let it settle there.
Ready?
Okay, fully functional valves. No change in blood pressure.
We'll
Let's
save
take
that.
the
We'll save that.
1 second off, Flora. Okay. Let's take the inflow parallax off.
So
see how
what
it
you
looks.
need to see, make sure you don't miss the left. The non-usual is not the issue. I mean, it looks like it actually is rolled up a little bit. I think we have to recapture.
You must recap.
Test here. Test here.
Yeah.
Yeah.
Okay.
See?
So we'll recapture. So because this valve is have a
So we'll use this view for recapture.
bigger cells, it sometimes can miss and right up. So, but I also think with the fully recapture. So we typically, what we do now is to wait until he'll fully recapture.
Going-
I'm going to go
going-
in more,
yes.
and then I'm going to bring back,
Pull back.
and then you will
Test
start
here.
again.
No, not there. Yeah, wait.
Test here. Good.
Okay, yeah, start.
Because you want to center the catheter. That catheter is still in the outer curve, actually. So.
It's going to take some time. Remember, we did a full recapture here. Test here, please. Good. Stay here. Stay here. Patient already has a pacemaker, so I'm okay if it's 3.5 there. So test here again.
Good. Very good.
Yeah. So here, see, it's trying to go up on the left.
Okay, I think you're okay there.
Good. Okay, we should be fully functional at this point. Good. No change in blood pressure. Everything looks good. Okay.
Okay,
Let's
so
take a
take
picture
that.
here. I really like it. What
Yeah.
does everyone think?
Cannot post it.
Thoughts from the audience?
You send.
If we release now, you won't be able to post.
Can they hear us?
We can hear you.
Can they hear
Yeah.
us? Yeah, okay.
What do you think?
Do you want to go a little deeper?
We're thinking maybe a little deeper.
It can at times
So
be
let's do
squeezed
another
out.
image. Yeah, we like to do the frame alignment.
Yeah, let's take a
we call it.
picture here.
So, and
Okay.
we often notice that the left cut settles deeper and the non-cut's right here.
I am very happy.
Yeah.
I am very, very happy. I think we should take it.
Yeah, you can see that the left cuts, the frame is below that. So,
Flora?
anyone disagree? No, I don't have to. Yoko?
Well,
No.
be careful.
Now the wire comes back.
Okay.
Any disagreements? Tell us now, please.
No
They all
disagreements.
think you have to go deeper.
Okay. I want to pace now. Pace
Okay,
150.
So the operator one does not push or pull the device. Very important to know for the NAVITOR. I'm actually almost can be just neutral. You can technically say hands-free is a single operator procedure. So Sahil is controlling the wire.
Keep pacing, keep pacing,
Yeah.
keep pacing. Okay. Pace 120 now.
So
Not
they-
released. Wait.
Yes,
wait,
it is
not
wait.
It's
released.
still.
Yeah,
Okay, so
that's okay.
so one thing about this system is that it's the
Just leave it there for a second.
yeah. So our flush port was at 12 o'clock. We usually do it at 6 o'clock. I'm not. So that's
It's going to come off. Give it a second.
that's why you see this.
pull.
If you do a flush port at 6 o'clock, it doesn't happen as often. So the key is that the operator one does not push or pull. So he'll just now basically twisting to relieve the
Yeah,
tension.
see how just
The
gentle
two-
twist.
now you're
There are
off.
two of them. So
Yeah.
we need to
Yeah,
confirm. Well, we need
so-
to confirm the third one.
Yeah, it's already confirmed.
Good.
I confirmed it mentally.
Excellent. See? Leave the wire. We're going to post
Okay.
dilate.
Yeah,
Triple.
back up to
Back up.
80.
Leave the wire,
And
please.
push the
Advance
wire.
the wire.
Advice.
No, not yet.
Oh, let me remarry this.
Yeah, remarry, please, and then we will post dilate.
1 second, stay here.
Are we pacing? What do we got
It's
here
okay.
rhythm-wise? I think we're okay.
No, yeah, the patient has a pacemaker, so. But watch wire.
Yeah, this is just a wire. Give us a second. I'll give you some hemodynamics
No, we'll post dilate.
and then probably post dilate.
Let's do
Would
the
you just
aortogram
go straight to
first.
post-dilatation? I mean, you would definitely
Yeah,
need
we'll
to
do
do
an
it.
Absolutely,
we'll do an aortogram
Absolutely.
first. Floral, please.
Yeah.
It's
Floral,
CMAT. I want
okay,
CMAT. No, what did I say on the phase plan? 20. You don't have 20? You don't 20 CMAT. Yeah, I want 20 CMAT.
Floral for a second.
Can you floral?
Yeah. Okay, 1 second. Oh, yeah. Well, go ahead, Flora.
What was the mean diameter? Just to refresh your memory.
Okay. Let's take a picture here.
Oh, okay. So 22 CMAT. Sorry. Yeah, 22 CMAT. I apologize.
Okay,
Perfect
let's take a
depth. Look at
picture.
it.
Yeah, take a picture, please.
So because the annular LVOT calcium, we wanted to not go for semi-compliant balloons.
Good.
You can see actually, despite the left cuts looked high, you can see that it pivot deeper on the left.
It's good. Yeah.
So
Yeah.
this is more
Yeah.
cuts overlap view.
Give me the balloon. It looks very good. Depth looks very good.
No, we need to go on the cuts overlap view.
It ended up a little deeper.
No, we
No, this is
post
good.
dilate
This
now.
is-
We
this
just
is
post dilate
We're
on
in
this
good
view.
shape.
Everyone liked it?
We like
Yes, I
it
think
over
was a good
here.
depth. Yeah.
Yeah.
We're waiting to
I think
see
they just popped the
hemodynamics.
balloon. Will be- Sure. I just want to post
Yeah,
up
let us
this and then.
post dilate first. Now again, this patient is young, right? So we want to be able to think about under expansion, especially in the context of the accurate data that was presented at TCT. So we don't even look for PBL or check for echo. And for us to be an RAO photo projection, that's the short axis of the annulus. That typically that's where you see the under expansion occurs. So yeah, that's why we are post dilating. This is with self-expanding in particular. If we post dilate, we post dilate in this short axis for two reasons. One, if you have annular calcium, like in this case, you don't want to be too aggressive, and you want to watch how it looks on the balloon interaction with the stent frame. Two is that because this is the short axis, you actually be better seeing the expansion, be able to see how it looks. And we're using a semi-compliant balloon for that reason here, because we don't obviously want an annular disruption.
Leave the wire, guys. Leave it. It's okay. Keep pacing. Keep pacing. Good. That's it. That's it.
I think they need to go down more.
Pacing. Yeah. I think just okay. Let's walk it out. Okay. Go to backup pacing.
So you
Give it
can
a
see
breather.
it expanded, right? Compared to before, the balloon versus that, it did warm up a little bit.
Yeah, the balloon actually rolled up a little bit, but
Not full expansion, but at the same time, there's risks and
yeah,
benefits.
let's take a look on echo.
Right, you're not gonna expect like full, meaning like in vitro, like out of the body expansion, right? Remember, this is a 25 NAVITOR in the annulus that you otherwise would probably put a 20 S3, maybe a 26 FX. So we know that it's not going to be fully, it's slightly, but we just published the paper in JACC Intervention, Sahil and I, with the research letter, working with Ole de Bakker's group in Copenhagen. When look at the post-CT frame geometry of the NAVITOR, and actually it starts to circularize at the first half the diamond. And it actually mimics similar to the LVOT platform in terms of the expansion of the frame. So yes, it's an intra-annular platform, I think, but we have seen excellent hemodynamics, at discharge and at 30 days with this valve, despite its intra-annular design. So, but to do that, I do think that you need to post-dilate, judiciously to optimize the expansion, because otherwise, I do feel that you will have an issue with durability and gradient longer term. And we've seen that on CT as well, how it actually really nicely expands and conform to the native anatomy.
Sam is showing some great echo images.
Looks great. No PVL, no pericardial effusion. And peak gradient of 13.
Awesome. When we close the case, everyone agrees?
Supposal.
Any questions from the
Any panel comments? Yeah.
question? Right? He said finish the case. He was interested in the mitral valve. David, you're still.
Let's see the mitral.
Yeah, I think it would be interesting to see what the mitral valve gradient is now.
Yes, we can get that. Okay, Professor, let's get the apical. Yeah.
I mean, the MS should not improve, right? MR might improve, but MS should not.
Yeah.
All right.
Can anybody hear us?
Yeah,
can
we hear you well.
Yeah. So they just look at the mitral gradient now.
Yeah, that's sort of a PVC there, but
Yeah, there's some atrophy, I think, from the TVP.
Yeah.
Maybe we should remove the TVP.
Four.
yeah.
This is the mitral, right?
Mitral, yeah.
I want to remove the wire from the LV. Just 1 second,
I
please.
have it.
Yeah.
So we're gonna give you some. Okay. Yeah. So we did the hemo already. So we're gonna kind of pull back the TVP.
Four again.
Okay. There was a TVP irritating the heart. That's why you got all these extra beats. So.
Okay, let's get the.
All right. So yeah, that's it from this case. I hope that you appreciate
What's the plan? Who's moderating? Who's moderating? We have more lectures. The next case would be the septal ablation case.
Yeah. So we'll set up the septal ablation case for you,
You want
because
to
we
do
do
lecture
have
first or go to the lab?
One lecture and we'll be ready by the septal ablation.
Yeah. Why don't you guys do one lecture next, and then they'll be ready in room 2.
Sounds
Thank you,
great.
everyone.
Very nice result.
Thank you, Anil.
Dr.
Thank
Adams, did
you.
you want
Thank
to
you.
make a comment on the mitral?
Nice job. Maybe what we could do is just have a discussion here for a minute.
Yeah.
Yeah, I didn't get the beginning of this. He was 68, cured of Hodgkin's disease.
Yes.
Has radiation, heart disease with an STS of 5, with severe calcification of the anterior leaflet. I see Mike up here. Maybe he's going to comment. Severe calcification of the anterior leaflet with a grading of 8, which is, yeah, I agree, 5 to 10 is the range, but 8 and 16, we've operated up for less gradients for symptomatic MS, and I'm assuming the patient was symptomatic. How do we sort out the symptoms in that complex scenario, like what's AS and what's MS? Because if you're wrong, which you will be eventually, Yossi, and I agree on that, if you're 68 and otherwise cured, you're not going to live to blow out your 86th birthday candle without mitral valve. And the surgery is going to be more complicated. It's already complicated. It will be even more complicated. And I've seen this pattern is emerging and I don't know what the evidence base, how we even create one, meaning the aortic valve is the easiest valve to fix. The mitral valve is the hardest valve to fix, transcatheter with a catheter. So many times I see the consults where they're sending me patients from everywhere for double valve disease, and one option is always listed. We could treat the aortic valve now and then make a decision about and then if the patient needs something under the mitral valve later, they can have that done, but it's an extremely difficult operation because the mitral valve, the hinge point of the mitral valve is now included in the TAVR, which makes exposure of that corner of the mitral valve difficult.
Yeah.
And oftentimes that valve either gets distorted and we have to balloon it again or take it out. So it's not, I'm not sure we're there. I'm not sure how we got to the point of staging multivalvular heart disease starting with AS. Unless it's certainly you can make that argument, but it's tricky.
So let me ask you another question.
By the way, just to tell you guys that yesterday I saw a patient that was referred to me where the plan was we can't do a mitral. She's not a candidate for mitral intervention, but she has severe MR. She's not a candidate for a TriClip or EVOQUE, but she's not a candidate for a TriClip, maybe EVOQUE, but she has severe TR, but she has moderate AS, so why don't we do a TAVR in the AS, then we can revisit for EVOQUE. I'm not making this up.
Yeah.
It's written in a medical, this is the note that showed up.
No.
She happens to be a doctor, so she was trying to understand all of it herself. And I said, I'm not sure I understand it yet, because I do think this is the quandary that I think all of us in this field of valvular heart disease have to be protective of. Just because we can treat one valve with super incredible technology really safely and dependably, we don't really have a great evidence base for leaving moderate to severe in every other valve. And look, if the patient's 78, break a leg. See if you make them feel better. You're not making them live longer. 67, cured of Hodgkin's. I don't know what the rest of his, medical condition was, but if you got a 15 or 20-year life expectancy, I think we at least have to have the discussion, because Ishmael and I did this case a week ago. Exactly this case. I forget how old the patient was, Ishmael, but exactly the same case. Whenever we do those here, we combine our approaches, because obviously both of us bring very different skill sets. So we'll do the mitral, and then invariably you have to do a complete root and often replace the aorta. And then you also have to think about, can you clamp the aorta? Do you have to cool down a circle rest to get it? It's an operation. It's a real operation, but they can be done with remarkable success these days in really advanced centers. And that's why I'm bringing it up. But I'm curious what the rest of the panel thinks.
This sort of echoes the theme that we've had all day, is that, transcatheter world is a tool, a singular tool for a singular pathology, and do we use the tool or not? Whereas you guys have a toolbox. Then you can do multiple things. You can do double valves. In this case, the clinical issue is what's the dominant lesion? In this case, it seemed to be severe AS with moderate MS. Okay, so we have a good therapy for the severe AS. Presumably, she's not symptomatic of moderate AS or moderate MS. You're not supposed to be. That's supposed to be why it's moderate. So I think it's reasonable to assume that the AS therapy was the right and only thing at the moment. But eventually, we have to understand, what do we do with mixed severe disease? Do we have multiple tools? I think we have a long way to go until we can compete with surgery from a transcatheter-only approach.
I think, the treatment pathways are customized to every patient. But I think, in general, I think the key is to work up the mitral ahead of treating the aortic valve. And if we do not have a percutaneous treatment option for mitral, especially in a patient like this, you could argue that consider dual valve surgery, But there are TMVR trials, and if the patient is deemed high risk, of course, by the heart team.
That's what I mean. We can't, I'm sorry, I got to stop you there. We can't throw that out. There is no TMVR in the planet of the 35 patents out there that's going to treat that. You've got a rock calcified anterior leaflet into the outflow tract. And that's what I mean. When we come to these meetings, we just can't say that. That is not going to, at least, maybe you guys have all can share with us the technology that we haven't seen yet, but unless you've got a laser atherectomy, that actually valve is very difficult to do even under direct vision with surgery to even try and, we now have ultrasound to cut these leaflets out, but it's tricky. This is no panacea to be able, you have to really tell patients like that, you're not sure you can replace the mitral valve intraoperatively, even with structural standby, because a lot of times we put felt around a sapien and put it in under direct vision. So we have everything in the room, but even every now and then you have to back out on the mitral side. You can't do it. So there is no structural therapy for this. We're not talking about in general, work up the mitral, we're talking about this case. Severe MS, severe calcification of the hinge point, or let's say moderate to severe MS. And we always go to moderate when we want to leave it alone, and it's moderate to severe when we want to treat it. Have you guys ever noticed that? But now we're in 3-stage because we're not going to do it. But a grading of 8 with that severe calcification, a peak grading of 16, I have no idea how they calculated that in terms of what the actual peak was or exercise. But these are very significant gradients and highly unlikely to not require intervention in the future. And that's what I mean. If you're older and you have a limited life expectancy, I have no problem with target culprit therapy of structural valve intervention. But I don't think we have any evidence that works very long in this space. I will say that this is not an uncommon operation we get asked to do. The patients had a TAVR, and now 2 years later, the mitral stenosis progressed. That's why I got up today, because I do think it's an issue we should really think about. This is very different than MR. MR, you can always do a clip, even a palliative clip, something else if you had an older patient. But MS, it's really tricky in the catheter world.
I'm a big believer in transcatheter technology amongst the surgeons, but I think in this day and age, for multivalvular disease, any of the low and intermediate risk patients should go for surgery. That's a given. But even in the high-risk patients, if the second option that you're trying to provide, in this case mitral stenosis, like you said, there is nothing that we might be able to provide. In those patients, we have to be very careful on selecting the therapy at this time. So this patient, aortic stenosis with moderate MS, that MS will likely be a problem in the future. If I were to see this patient, I would probably recommend surgery to treat both at the same time.
But how easy is that surgery, Yoshi? Because
This is
your
hard.
entire intravalvular fibrosa is a rock.
Oh, yeah. I think you probably
Right.
have to reconstruct that aortomitral curtain. There's a
Right.
very high likelihood.
Yeah.
So we have to be prepared for that. But, I've had the other side of the story. These patients have
Yeah.
TAVR. They come back with severe MS, very symptomatic, right? And now all of a sudden, these patients become a surgical candidate. And you have to really watch out where you clamp, because we put a very high, tall frame valve. And then if you end up with paravalvular leak, the protection strategy becomes very difficult. And then, as Dr. Adams said, that nitinol stent can push on the mitral annulus, and you just can't see it too well. So you end up taking out the TAVR valve. And you're going to do
I know we have to move on to the debate, but I'll say again, we always use this phrase lifetime management. That's the new one, like heart team, multidisciplinary team. The new word is lifetime management. And lifetime management for this patient is not, unless you think his life expectancy is limited, it's at some point the mitral valve is going to have to be dealt with. So it doesn't really matter how risky it is, because it's going to be more risky now. 3 years later, more severe stenosis, higher pulmonary hypertension, increased right heart failure. You haven't changed the technical problem we're in front of us. It's not like, well, we made it easy for you because now you have you don't have to worry about the aortic valve. But the aortic valve, in all likelihood, will have to come out to get to the mitral valve. And that's the reason I got up, was just to educate everyone that one of the harder operations you can do is a mitral valve replacement in the setting of a TAVR. It really does require a transseptal approach. Many surgeons aren't familiar with that. Oftentimes you have to distort the valve at a minimum and come in and redo it. Gilbert's come to the OR and re-balloon them for us. And sometimes they come out. And so it's not, you're not helping this patient by doing the TAVR first unless you think the mitral stenosis is not going to be an issue over the next 5 years, which I really doubt. Yeah, none of that's what I mean. None of that's going to go away. But I'll answer the corollary of that. When you have the discussion with the patient, are you going to tell them we're going to palliate you with an AVR? There's nothing we can offer you outside of this, and if this doesn't work and you get more symptomatic, you're inoperable. That discussion has to be had. That's what we owe a patient. I'm bringing this up just to get your all's reaction, because the next 10 years, this is going to be an everyday conversation in a 75 or 80-year-old or someone with radiation heart disease. Because what happens now is these patients get a TAVR and then they are sent to surgeons. There's no way this patient gets a TAVR and is told, you're inoperable, don't go see a surgeon. They're going to see a surgeon. They'll go see one themselves if you tell them they're inoperable. But I think that it's a great topic, which is why I got up here to talk about it, because I really do think this is one of the things we have, this kind of case we really have to present more and talk more about. I'm not sure I know the answers, but I do know that mitral valve is going to need intervention at some point, and the only intervention I'm aware of in the future for that is surgery so far.